Good morning, and thank you very much for this very generous introduction, Dr. Christie. For all the postgraduates here, you might say you introduced me as the editorial board member of JAMA Ophthalmology. But for all these things, and I've learned it across the country when I go about, I'm better known for the FAQ book, which helps them pass the exams. I think that is the most important thing a postgraduate would like to hear from that. So once again, there is an advantage of being a keynote speaker. Usually, at least usually, they don't stop you when you're exceeding your time, and hopefully that would be extended to me as well.
You're never going to stop, sir.
No questions asked as well. So I'm going to tell you like a story. Can we switch off the lights, please? It's going to be like a story. The advantage is I don't need to stick on to a written concept. I can just tell like a story, and you have the freedom to sleep because it's just a story and it's not science. So the first point I want to make is I started doing LASIK surgery when some of you were not born. So it comes off with that kind of an experience and with that kind of an insight. And so I really want to pepper it with a lot of experience rather than just science and putting some data into it. So that was early days of LASIK in Tamil Nadu. We had LASIK in Chennai, but then we were starting out in 1998. So we had the first machine. Bosch and Lohm bought the first machine to Madurai. And Bosch and Lohm did a lot of other things because they wanted to market it very badly. So they brought in Michael Norris. I'm sure you would know the name Michael Norris if you're doing refractive surgery. And he was the president of European refractive surgery at that point of time. Bosch and Lohm did not stop with that. They went ahead with all the senior ophthalmologists, and they said, Michael Norris is coming to Madurai to do the surgery, and we are going to offer all of your children free surgery. So inauguration day, we had Michael Norris, we had 10 senior ophthalmologists in the state with their children. Because it was going to be a free surgery by Dr. Michael Norris at Madurai. What better things you can ask for? So the first surgery, right eye, was done by Michael Norris. First eye, buttonhole. First eye. Outside, there was a lot of press, a lot of senior ophthalmologists, Michael Norris, Bosch and Lohm, and Dr. Prajna. So imagine that situation. Not even the second eye, not even the fellow eye, the first eye. So I cannot forget that day, but I became mature by 10 years after that incident. Nowhere I could camouflage that it was an unintended complication because these were 10 senior consultants of Tamil Nadu sitting with their children. And one eye of one patient already cut halfway through. So some of my thoughts, which I will be presenting in the later part of my talk, you will have to understand it in this context of what started, how I went through this process. Sometimes you see a very successful person, but you don't see the pain behind it. You don't see the experience behind it to have made him such a sort of a strict person. So at that point of time, 1998, topography was all about anterior corneal curvature. There was no idea about pachymetry. It was just anterior corneal curvature. If the anterior corneal curvature was steep, then you just don't do LASIK on that patient. That was how we started at that point of time. The surgery had to be deciphered on a case-to-case basis. There was no YouTube. or no CME like this, where you can get the experience out of people. And so you had to do it on your own. And you have to rely sometimes mostly on the technicians who used to install these machines. Sir, summa pannung sir, Madrasla அவர் பண்ணிட்டு இருக்கிறார் sir. That would be the guidance given to you. That would be the ideas which would be given to you. So I'm always, you have seen this statement. You have to be tough. You have to be this. You have to be that. It's very nice to get a theoretical version of it. And so I was in that mood, maybe at your age at that point of time. And so I'll just show you a video of how we went that. At that point of time, we did microkeratome, no femto, no nothing. So microkeratome used to be, it started off with 160 and 180. It didn't have a 140, 120. It started off with 160, 180, and we had a 140 at that time. So I'll just show you. Some of the slides might not be very clear because of that time period. So this is how I started off with a 140. Oops. Naveen, how do I play this? Okay. So here I go, start off with a microkeratome with a 140, and I realize it is not going through full, right? And so at 140, it came halfway. I knew it went halfway. And at that point of time, I didn't know what to do. But then I had an idea. Now let us say I did 140. I have an 160 with me. I have an 180 with me. So let me cut deeper. That was my thought process, because no YouTube, no this thing. So here I am trying to see, and you have to also imagine my pulse rate. So see this, now I don't know what to do. As you can see, biding away my time by clearing the peripheral cornea for no reason. And now with 180, the tough, when the going gets tough, the tough gets going. So I go off with a 180. This thing with that same eye, because I didn't want to save the patient. Now I say, okay, now let me do the flap. Now I see it at low magnification, and I want to confirm it with a higher magnification. Here I do it. And then I look at it. It doesn't look like a corneal flap. It doesn't look like the regular corneal flap. And I take time to assess the damage. Really don't know what to do at this point of time. I should have stopped at that point of time. And at that point of time, I was recording all my cases so that this thing. So here I was at that age. You will have all the guts. You will use all the instruments, even the carpenter's thing, wherever it is there, you will use that to sort of decipher it. See the flap which is moving like that. And this is the statement which I made. The problem is this gets even more tougher. So one of the things when you're doing refractive surgery, whenever you have the first doubt, stop. Just stop. Wait for a better day. Plan, and then go back and decipher what you can do after a period of time. Don't ever forget this video which was shown to you now. So fundamental thing is, what is abnormal depends on the measurement tool. Remember, I told you that topography was the only, what we thought topography was just the anterior corneal curvature. And then pachymetry came into play. So we had keratometry and pachymetry. Now then it went to topography and pachymetry. Then it went to tomography, as Sharmila was mentioning about the difference between topography, tomography. And then now with biomechanics, it's just not the structure alone. Functionally, is the cornea stable enough to withstand all these cuts? What is also abnormal of cornea has also changed definitions. Initially, this was our warning thing. And then all the definitions mentioned by Dr. Sharmila here, and posterior float, and then altered corneal hysteresis. So this 25 years, there have been a change in the way we sort of measure astigmatism. We sort of determine which are the corneas which are left alone or which are the corneas which you can go this thing. But you have to also understand we've been old enough that today what you think is the current thing will be laughed at, just like how you are laughing at me. It will be laughed at 25 years from now. That is another concept you need to keep it in your mind. Nothing is current. It's all, you're just part of the tide. So that is what Josephine was mentioning. Whenever I teach, I like to teach it in a perspective so that nothing is etched in stone. And today's thoughts are relevant for today and maybe for some days to come. So that is another concept you need to keep in your mind during your younger part of your career. So my talk starts now. But I think the previous 5 minutes or 10 minutes was very important for you people to have got the gist of this thing. So let me talk about the structure of corneal stroma. The corneal stroma is not one structure. That is the first thing you need to understand. So you have dermatan sulfate and you have keratin sulfate. And you have dermatan sulfate, which has a great water retentive capacity, and a keratin sulfate, which does not have a great water retentive capacity. Don't bother about all these things. Just get this concept that stroma itself is not one structure. Okay? This is the second thing I want you to understand. This is the epithelium. This is the stroma, thick stroma. You have an anterior stroma and you have a posterior stroma. And the anterior stroma, the fibrils are actually woven. While the posterior stroma, the fibrils are non-woven. Again, the concept which you need to understand is within the stroma, the fibers are arranged in a densely packed or a loosely packed manner. That is it. That is the only thing you need to understand. But the concept you need to understand is this 40, 50, 60 thing. The posterior 60% of the stroma is 50% weaker. It is not slightly weaker. It's 50% weaker than the anterior 40% of the stroma. Why does it mean? The deeper you cut, the deeper the protective layer is what you're taking out. If you are able to understand, it is not 400 microns. It is not 300 microns. It is the amount of anterior stroma you're taking out, which is going to matter. So if you are able to get this concept also into you, that is much more easier. You know, from a postgraduate point of view, the problem is you don't want to complicate things by telling them everything. But then if you're able to communicate to them in a language which they understand, then you're able to communicate to them much better. But this is the concept you need to keep in mind. Cornea is not like this. Cornea is not like this at all, but the cornea is like this. It is very easy to take out one book from this without dislodging the whole rack. This will be tricky, right? This will be tricky. So this is what you need to understand, the removal of any tissue from a structure. So you have to really understand your topography, whether your cornea is resembling this or resembling this. Because even in this, if you're going to take this much amount of a thick book, nothing is going to fall flat. While if it's going to be a rack which is arranged like this, taking out one book in a different direction can cause the entire book rack coming down. Okay, that is another concept you need to understand. So that was about the structure of corneal stroma. You just need to understand only that. You don't need to understand all the micro details. The incidence, just to suffice to know that when we didn't know anything about tomography, the incidence was more. But since now we know about a lot, the incidence is comparatively less. And when the incidence is less, we really don't have a good treatment plan. Because the incidence is so less, it is not like cataract surgery where you can refine your surgery right, left, and center. So the incidence is really less. And so your chances, I might have one treatment plan. Christy will have a treatment plan because we're just going to see these cases in a different thing. But what we know is there's no case of ectasia after hypermetropic LASIK. So it's something to do with the central cornea, something to do with the thickness of the central cornea. Incidence, the real studies now say that the incidence is similar in LASIK and a SMILE. I told you about the 40, 50, 60. Forget it because anything, don't forget it because it's all about removal of tissue. But interestingly, there have been studies which says the flaps created by microkeratome blade, you have the incidence is more. And why? Because in a femto flap, so here it was intended for 145. You see, it's almost similar. Like it's an even cut. While in a microkeratome flap, the same thing, where it was intended for 160, you have all the way from 197 to 159. It is not a planar flap. It is a meniscus flap. And because of the meniscus flap, the seating, you have to remind yourself of the rack, which I was showing you about, the book rack of the cornea. So it is the flap seating, which also will integrate, even if it is from the superior part. So that because the integrity of the cornea as a whole is also important and not necessarily the thickness of the cornea. And don't worry about the stromal hydration part. Just remember that if you are going to do LASIK, femto has a lower chance of getting a ectasia. Now, what are the risk factors? These are the risk factors, and I'll just go through these risk factors one by one. The first thing is the topographic map irregularities. Anything which is steep, don't do LASIK. It is a definite risk factor for getting a post-LASIK ectasia. Anything which is skewed, that is not respecting the vertical axis, not respecting the horizontal axis. Anybody who stands like a model, it's good for you to see it as a model, but not for this thing. The only problem when I talk like this is everybody forgets the whole concept. At the end of the thing, only the model stands this thing, but as long as it's okay. But the skew part, whenever you see the skew, whenever you see the model, you just know, okay, this was what he was referring to. Because skewing, it's a very difficult thing to explain, but this is how it is. So topographic, two important things you exclude. Thin cornea, definitely higher chance of ectasia. And this was another important score, but this was designed before the new tomograph. You just need to understand these things. Don't worry about all these things. I'll just explain to you very simply. So these are the 5 parameters by which you can do a risk analysis. Here, the chance of ectasia is 0. If the topography is normal, if the residual stromal bed is more than 300 microns, patient above the age of 30 years, the lower chance of ectasia, because as you know, the chance of ectasia, the cornea becomes stiffened even by aging process. So you have to give a weightage to the patient's age and the corneal thickness and the manifest refraction. Likewise, 2, 3. So this was what they found out. But what is important is it's not only the topography, it's not only the residual stromal bed, but it is also age. And this is available everywhere. And then anything above 3, you have a higher chance of developing an ectasia. Percentage tissue alterations is, suppose you start off with a 600 micron cornea and you leave out 275. The residual stromal bed is 275 microns. It is still risky. Let us say you started off with 500 micron cornea You lift 275, it is not that risky. So that is the point you need to understand. What started and what ended. So it doesn't mean that it doesn't just depend only on the residual stromal bed. It depends on the thickness at which things started. So that part also you have to understand. You have to understand the word compactness. That is the word. Just again going back to a model story. It's about compactness. But the only thing is the increasing the age, here the compactness becomes more. That's the only difference between the examples I was talking about. I'm not going to talk about enhanced ectasia display and this because Dr. Sharmila really mentioned a lot of things about this. So she used the word, Dr. Sharmila used the word, see the map in totality. That is the most important lesson you need to understand from that talk. We were talking about keratoconus and post-LASIK ectasia. The fundamental difference in the pathology is in keratoconus, there is an increased enzymatic degradation activity. It is the enzyme degradation which causes a deformed structure in keratoconus, while here we create a sort of a degradation of structure by mechanical. So that is the fundamental difference between these two. And the confocal microscope is the epithelium density is increased in post-LASIK ectasia. Usually in keratoconus, the epithelium also is thinned. In fact, there are newer machines which are now able to capture the epithelial thickness. So you need to understand that part. Also the only thing is the nerve. This thing is similar between post-LASIK ectasia and keratoconus, but the enzymatic activity is very, very less. I'm not going to get into the treatment principles again because I have said, but I'm just going to the final part of my presentation about the lessons learned, which I think is more important, which I think is practically more important. So I like this example. So just by adjusting, I'm not adding any English letter here, just by reforming the same letter, you are able to get a different connotation, maybe the same meaning. I've not altered anything. If you really see, nothing, the same letters. So sometimes just the alteration can give you the same meaning, and sometimes the alterations can give you a different meaning. But I have not added any one this thing in this. Just rearranged it. So just the rearrangement of letters without adding, without deletion can cause either a same meaning or a different meaning. And I'm sure if we vote in this audience, if it's the same meaning or a different meaning for this slide, there is going to be, I don't want to make that statement, but you understand, right? You just need to understand the concepts when you come to a conference, because all the other things are available in YouTube. Right? You just need to get the messages and concepts from people. So we know this is normal. We know this is subnormal. But the problem is the patient's cornea is neither normal nor abnormal. And the patients, as a postgraduate, you're very clear about topography. After you finish an 18-month cornea fellowship with me, you're totally confused because they are all shades of gray. It is not about just black or white. It's all about shades of gray. And let me just show you some example. So this is some normal pachymetry with keratoconus. See this same patient, 521, reasonably normal pachymetry, but then you can see that there is a difference of more than 100 microns between the central cornea and paracornea. But then if you just see casually, you may get destroyed. Then there may be steep, again, thin cornea, no keratoconus. See, again, you have 438, thin cornea, slightly steep, but no keratoconus. You can have high cylinder, as you can see, 41, 47, 46.3, no keratoconus. So this is what Dr. Sharmila was mentioning, see everything in totality. So That was about that other concepts. I'm just going to end my slide, but with a long lesson list. I have 10 lessons for you today. Statistics does not help, ultimately. If you see a topography map, just ask yourself this question. Would I do this if it was my son, my daughter, or my sister's son, or my brother? The answer will be very clear for you. Otherwise, Rabinovich சொன்னாங்க, வடிவேலு சொன்னாங்க, அவங்க சொன்னாங்க, இவங்க சொன்னாங்க doesn't help at all. That's okay for you to pass your exam. But for your practicality, you need to understand this concept, which you have to, when you do this surgery on your closest relative with this topography map, if the answer is no, forget LASIK extra, forget PRK extra, forget every extra. Let the patient go to somewhere else. That doesn't matter, but at least in your conscience, you're very clear. The second lesson, every machine is unique. The patients sometimes are very upset. They have an op scan with them. And when we say we want to do another machine here, people are suspicious. Another scan they're doing. But you have to understand, especially when you're comparing for progression, don't compare between machines. In fact, I don't even compare with the pentacam of AEH Coimbatore and an AEH Madurai. I mean, I'm going a little bit too far, but I just want you to know that the machines are finicky. Each machine is telling its own story, and you are deciding based on that story. So you need to understand that fundamental concept. The data is not comparable. Lesson 3. Topography needs to be carefully interpreted. You can see this person reading a book, but actually it's not a person reading a book. These are multiple stones in a stream, which just looks like as if put forward. It just looks, because if you're just seeing it in one perspective, in one direction, one dimension, it just looks like a person is reading a book. But these are just isolated stone arrangements, which just confuses you as to that there is a person sitting in a water and reading a book. So you have to understand that one, it has to be carefully interpreted. Listen to the patient. Christy was telling that when a patient goes out of my room, the patient feels happy about, but then I have to work for it. People, at least I can see 30% of the audience are somehow my students, or 25%, I would guess. They would have seen me talking to a patient. It is painful, but what they are going through is even more painful. That's the point. What they are going through is even more painful, even more disappointing. Do not dismiss the persistent complaints of the patient. See patients with complaints more frequently. This is the thing you need to understand. The tendency would be to avoid such kind of patients. See these patients more frequently, and I'm telling you that will help you reduce your legal problems in the future. Not all ectasias present with a cylinder. Don't think your ectasias will present with a cylinder. Be careful of increasing myopia. Sometimes it may just present with a sphere, -2 sphere. And then next time it goes to -3 sphere, not even the first cylinder. So you have to be careful. When in doubt, to do a post-op topography. Do not hesitate to repeat topography at frequent intervals, especially if the complaints pertain to visual acuity. You might have done a topography 1 month back. The patient's complaint is increasing. The sphere is increasing. Please do a repeat topography. Ascertain yourself that this is just a regression and not an ectasia. Do not rush to enhance. This is another thing. When you have having a -4 and the patient is coming with -2, you would like to do an enhance. Sometimes it's safer to leave the patient with a residual refractive error. I just want you to see this video.
Park rangers in Africa try relocating a leopard back into the wild, but it won't budge. Rule number 1, never poke an angry wildcat with a stick. sticks. Now it's the leopard's turn to do the poking. The ranger's pretty beat up, but he...
Before you do an enhancement, remember this video. In this talk, you remembered all things when I did not use ophthalmology as an example. Also remember that when you are going to take a class, it's much more easier to sell a concept rather than to teach an etiopathogenesis or any other things. So I told you don't enhance just casually, because if you poke, it is your turn to get poked. So that is one thing you need to understand. The first thing is, whenever you will definitely be in a safe source of denial. The patient comes with complaints, there is a doubtful ectasia, immediately you'll go to your pre-op topography. பாருங்க, இதுல என்ன ப்ராப்ளம்னு பாருங்க. ஒரு ப்ராப்ளம் இல்லை. ஒரு ப்ராப்ளம் இல்லை, வாஸ்தவம். Now the patient has a problem. So that is the thing you need to understand. First thing, first chance, just do a C3R. Don't wait for progression. You wait for a progression in a case of keratoconus before you do a C3R. You don't wait for a progression when you have a post-LASIK ectasia before doing a C3R. These are the two fundamental differences between doing a C3R for a LASIK ectasia rather than this thing. At the first doubt, just do a C3R. When you get a post-LASIK ectasia, a very humbling experience. You have to understand patients have a right to get disappointed. Usually, and you won't believe me, again, there are 5 or 6 people, 7 or 8, I can even say 8 to 10 people who have been trained with me. You can talk with them to see how I handle my patients with post-LASIK ectasia. And I thought I'll just show you some emails. I've protected their names. But I think it really makes sense for you to read this email, even though it looks long. I'll give you 1 minute to read. So this looks nice, right? For always being with me. Always being with me. I have spoiled her cornea. That is one thing. But see this one. Both my kids diagnosed with juvenile idiopathic arthritis. She's already stressed with other things in life. Don't you think she has every right to be angry with you? But see the language which is this thing. And see this one. One thing I have found out is whenever the PRK patients who I do or this thing, they just go and join the army and they're very, very happy as a Havildar. All my post-LASIK ectasia seem to be either in the US or UK or Singapore or Malaysia. And that is where I have a problem. So you can't just bluff around. They get multiple this thing. So I can't try lenses at Singapore as they straight away push me for corneal transplant. Apple gave this another patient. I was able to set up a new team in Malaysia too. Now I have small teams in US. Everything, you cringe. This guy has small teams in US, but then he has a cornea which is crooked, which we made him crooked. Very, very difficult experience for us to even go through this. See this one, he's talking about his house construction. That is the level at which the communication will help in order to safeguard yourself. This is much more realistic, much more important for you rather than just the measurements, which will just help you give the direction. But whether you want to reach the harbor or not, it depends on the steps which you take before you this thing. So see this one. I have more stories to write, but in respect of your time, I will stop here. This one. This is another patient. I can suggest him to consult you on your available dates. This guy has already had a post-LASIK ectasia by me, and he wants to bring other patients to me. So these are real life situations. Naveen or Preetika or even Soundram here would have seen me explaining to my patients in detail. But I told you about, I was just telling you in a very smiling and laughing fashion. But imagine the pain from the first case of LASIK to every case of LASIK ectasia, which I go through before somebody becomes a senior. You see from a distance and say, oh, he's so and so. There's a person who's going like a scarred person in a battle with multiple scars which make you feel stronger and harder, but at the same time more wiser, so that you won't make the mistake again and again. Statistics doesn't help. 15% of legal cases in ophthalmology are due to ectasia in the US. And if there is an obvious keratoconus, a need for future surgeries are associated with an unfavorable outcome for the doctor. There have been studies published on the legal implications of doing this surgery. This is my last slide. We started off with PRK. This is my preference pattern. Then I went ahead and learned LASIK. I was feeling so nice about it. And then I went ahead and did femto. We didn't have it, but our Aravind Hospital, Chennai, had SMILE, and now we are going to put one up in Madurai also. But given a choice for people who are known to me, if there is an option to do PRK versus SMILE, PRK versus LASIK, PRK versus femto, I would any day do a PRK. PRK is not old-fashioned. PRK is what you would do for yourself if you were this thing. You consider haze, you consider pain, you consider this, you consider that. But I showed you data. So this is what is the message which I would like to leave you along with. Once again, thank you very much for a very, very patient hearing.